Hi, everyone. My name is Ashley Johnson, and my pronouns are she, her. Welcome to NAHUD's Bridging HIV and SUD Innovations in the Field webinar series. Today's session is perinatal substance use disorder treatment for HIV positive communities. We invite you to chat. We invite you to use the chat to engage with your fellow attendees. To start, please add your name, organization name, and our icebreaker question of the day. What's your favorite Super Bowl snack? Mine is soft pretzels with cheese. Throughout the session, please use the Q&A pod to add your questions. The speaker will address them at the end of the presentation. Today's session will be recorded, and a PDF of the presentation slides will be added to NAHUD's website as a resource. You will receive this information in the post-webinar email that will be sent out through Zoom. You can also visit NAHUD's resource page on the website to find resources and view past sessions. NAHUD is a membership organization of 8 regional and 2 national AIDS education and training centers, AETCs, that support the AETC program mission. Established in 2010, NAHUD supports the AETC, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations in order to promote and educate on the work of the ATC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network, ORN, to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, recovery, and harm reduction of opioid use disorders and substance use disorders through the provision of locally designed education and training. Visit the website to submit a TA request, read case studies, see featured resources, check out upcoming ORN events and trainings, learn about ORN work groups, addressing health disparities, and more. There will be a post-evaluation survey that will be emailed to you after today's webinar and must be completed within 2 weeks to receive CME, CNE, Social Work CE, or Certificate of Attendance. After 2 weeks, once the survey is closed, it will not be reopened. The minimum attendance requirement to receive CE is 60% of today's webinar. Participants who accrue less than 60% will not be eligible for CE. Certificates will be emailed within 3 weeks of completing the evaluation. CE credits issued for participation may not apply towards license renewal in all states. Each participant is responsible for verifying the requirements of their state licensing boards. Today, we have the pleasure of having Dr. Molly Neeson. Dr. Neeson is a dual board certified family medicine and addiction medicine physician whose clinical work focuses on the intersections of substance use disorder and reproductive justice. She proudly serves as a clinical director of the Empower program, an outpatient perinatal addiction medicine program at Cooper University Hospital. Without further ado, I'd like to introduce our speaker, Dr. Molly Neeson.
Alrighty. Are my slides up and looking okay? Thank you so much for the introduction, Ashley. So my name is Dr. Molly Neeson. Can you hear me okay and see slides okay?
Yes.
Okay, cool. Thank you. My name is Dr. Molly Neeson. I am an addiction medicine doc. I focus in the care of perinatal, pregnant, and parenting individuals. I work in Camden, New Jersey. I did my training many different places. This is why I do this work. This was This is a former patient of mine who, with not only with her explicit permission, but her explicit demand, I share her story every time I do a talk because she is the reason why I do this work. This is Lashana Johnson. I met her as an intern on Night Float, and she was pregnant with this beautiful baby who is now, oh gosh, she's probably 7 years old now, and had a substance use related health complication, and ended up in the ICU. And I had a really profound and life-changing experience in advocating for Lashana's care because she was not getting the appropriate care she needed because of stigma about substance use in pregnancy. She is now 8 years sober and awaiting a lung transplant. And this is 3 generations of their beautiful family for whom I was able to serve as primary care doctor for the majority of the last 10 years, which is a true honor in my career, and also just very much why I do this work. A couple of small disclosures. I do talks like this for a lot of different organizations. They pay me sometimes, which is nice. And I don't think there's any actual conflicts of interest, but just for situational awareness, I am the PI of a state grant that helps administrate my substance use in pregnancy program in Camden. So today in this talk, we're going to be centering evidence-based and interdisciplinary care delivery for patients during pregnancy who may or may not be HIV positive and dealing with substance use disorders. We'll talk about epidemiology, diagnosis, and treatment. And hopefully by the end of the presentation, you'll be able to discuss the health impact of substance use in pregnancy, particularly as it relates to HIV treatment and access to treatment in general, articulate barriers to treatment for pregnant and HIV positive people with substance use disorders, and explain the utility, importance, and maybe vaguely some of the process of initiating MOUD, which is medications for opiate use disorder in pregnancy. So we're going to start with diagnosis, definitions, and epidemiology, move forward to treatment of substance use disorder in the perinatal period, and then talk about the impact of intrauterine substance exposure and the process of figuring out parenting and recovery. So how do we diagnose a substance use disorder? The lay way that I explain this to my patients is when a dependence or use of a substance starts impairing your life. And we start thinking about that. This is the DSM-5 criteria for how we diagnose a substance use disorder. It kind of falls into these 4 categories of, has someone lost control over a substance? So the language in the DSM is it's taken often or in larger amounts over a longer period of time than was intended. You've tried to cut back and haven't been able to. Is there social impairment? The next category, does it impact one's ability to attend work or school or have relationships at home? Have they given up like activities that they love otherwise because of their dependence on a substance? Risky use of a substance, so like continued use despite it being physically hazardous or having a negative impact on one's physical or emotional health. And then the pharmacological criteria, which are tolerance, meaning that one needs a larger amount of a substance over a period, over time. Someone needs more of a substance or a higher potency of a substance to achieve the same effect. And withdrawal, which is when we remove that substance that they experience a withdrawal syndrome. So this is how we make a diagnosis. I always think about breaking it down to what works for patients is a substance or your relationship to a substance impacting your life in a negative way. And that's when we're talking about a substance use disorder and where we depart from kind of risky or concerning use into what we call the brain disease of addiction. Language matters so much in addiction. People with addiction and HIV face dual, multi-layered stigma from not only the healthcare system, but society as a whole. And words such as addict, abuser, junkie can be incredibly stigmatizing. There are studies that show that clinicians who use these words like this in their clinical notes are more likely to be perceived as stigmatizing by a patient, and that patient is less likely to return to care. So as we think about the comorbidities of HIV and substance use disorder, creating a welcoming and destigmatized clinical space is critical to welcoming people into care. And I've kind of reviewed some of this terminology, so I'm going to skip this. This is a slide from the CDC about the toll of the co-occurring epidemics of substance use disorder. or kind of the epidemic of substance use disorder in pregnancy, and particularly focusing on opiates, which are kind of the primary um, focus in a lot of research. But of course, we look at all different kinds of substances and treat all different kinds of substances and use disorders. So the rate of overdose deaths among people who, and this is cisgender women, unfortunately, is kind of a trans exclusive study, but skyrocketed kind of starting in 2014 with the advent or kind of entry of fentanyl into the opiate market. We know that opiate use disorder has increased over the last 10 years. We know that overall, kind of in the last year, maybe overdose deaths have like kind of come over the curve at the top. But for the last 10 years, we've been experiencing skyrocketing rates of opiate use disorder and overdose related deaths. And we know that the fastest growing age related population is in reproductive age people. So we know between 1990 and 2014, there were 4 times as many infants born with neonatal abstinence syndrome or drug withdrawal syndrome than in 1999. This is looking again at the rate of NAS or neonatal abstinence syndrome per newborn hospitalizations. And on the left side, we're looking at 2009, and on the right, we're looking at 2018. The darker blue it gets, the more births affected there are. So this is kind of a proxy endpoint to look at the prevalence of opiate exposed newborns being born, and you can see how drastically that increased over that decade. And then looking again at the prevalence of substance use in the first year postpartum. So we know that the kind of peripartum period, so that's like during pregnancy and up to a year postpartum, are people who are HIV positive using substances. So this is from the decade, or a little bit more than a decade, from 2007 to 2019. This study was only looking at alcohol and marijuana, but you can see that up to almost 60% of individuals were kind of encountering some kind of alcohol or marijuana use. And then this is another study that was looking at a larger population data set, looking at the risk relevant risk of substance use disorder among pregnant and postpartum individuals with HIV. And we can see that the likelihood that they're going to be exposed to some substance is more often than not. And we can kind of draw some conclusions about why that may be happening. Here we see the prevalence of personality disorders and substance use disorders among individuals who are HIV positive. You can see that the rates of like any substance use disorder are about the same in HIV and non-HIV infected individuals. And I think that's kind of an interesting piece of data, but regardless, we know that people with facing both HIV and substance use disorders have more barriers to treatment. Risk factors for developing substance use disorder are probably to a significant degree aligned with risk factors for becoming HIV positive or seroconverting, and they all have to do with social determinants of health. So with addiction particularly, we think about social risk factors like trauma, intimate partner violence, IPV, histories of abuse in childhood, unstable housing. We think about psychological factors, mood disorders, and PTSD. What comes first, the chicken or the egg, can be hard to determine, but we do know that there is a very significant hereditary component with substance use disorder. Up to 60% can be based on genetics alone. We know that reproductive age patients with substance use disorder are more likely to experience intimate partner violence, to be unstably housed, to have an unplanned pregnancy, or to have histories of trauma or abuse. They are less likely to have earlier complete prenatal care, be up to date on routine health screenings like pap smears. This is my like tirade of the century, is pap smears for people who use substances. And they're less likely to feel trust in their healthcare providers. And you can see how for HIV positive patients, they would have compounded impact of the experience of living HIV positive and the stigma that comes with that as well, and how all of these predispositions make it harder for people to access care. So we're going to talk a little bit about treatment of substance use disorder in the perinatal period. This is my beautiful graphic that I'm very proud of myself for making. I call this the road to recovery. And this is just to give people an idea of what people have to go through to get to recovery. So when someone has a substance use disorder, HIV, and like, thank goodness with HIV and just substance use disorder to some degree, we have lots of avenues for like non-normative funding streams and coverage of treatment, but they're not always accessible to everyone. So does someone have insurance coverage? Can maintain their benefits? We have a huge problem in the state that I work in of people's Medicaid being termed or discontinued because they don't get their renewal paperwork because they have unstable housing or they move multiple times. And then all of a sudden they don't have Medicaid and they have an interruption in their care, which makes them at higher risk for a return to substance use. Can they then find a provider who will treat them for substance use disorder? The majority of rehabs and other substance use treatment facilities are in the country and just in general are scared of pregnant people. I will venture to say that most healthcare clinicians that aren't trained specifically to work with pregnant people, being like OBGYNs and family doctors, tend to be wary of pregnant people because there's concern of lack of education and comfort, and there's concern of legal involvement and things like that. So finding a provider or treatment facility that will take a pregnant individual can be a barrier. Facing stigma, we've talked about that. Just getting to a clinic or a treatment center can be difficult. Do they have childcare for their other children? Getting stable on a medication for their substance use disorder can be incredibly difficult depending on what you're starting. Can they then access that medication consistently? Do they have safe, stable housing, a safe place to go home to? It is so difficult for people to maintain sobriety and recovery when they are unhoused for so many different reasons. And which is why there's been so much interesting research around housing first models. And then navigating social services, making sure that you have WIC and TANF and all these things. And how do you do any of that if you were incarcerated recently and your insurance got termed and you don't have an ID? So the social chaos that comes with severe substance use disorder makes it harder to crawl out of the hole to find treatment. And then for pregnant and parenting individuals, depending on what state you're in, the legal landscape of what happens with substance use disorder in pregnancy can vary widely, and people can face very significant criminalization of substance use disorder in pregnancy, which can be another chilling effect or barrier to people accessing care. This is from ASAM, the American Society of Addiction Medicine, looking at the kind of the continuum or levels of care. So we've got like early intervention, this like preventative kind of thing, like screening people for high risk substance use. That's not quite a substance use disorder, substance use disorder quite yet. So this would be like an SBIRT model in primary care. We have outpatient services. I'm currently in an outpatient substance use disorder clinic right now. We have IOP or intensive outpatient, which is more like multiple times a week. There's partial hospitalization up through residential and longer term services. The bottom line of substance use treatment particularly for opiate use disorder in pregnancy is that MOUD or medications for opiate use disorder, and there are 3 FDA approved ones being Vivitrol and naltrexone, buprenorphine and methadone are the gold standard of care in pregnancy for people with opiate use disorders. And ACOG, which is the American College of Obstetricians and Gynecologists, released a statement all the way back in 2017, which was pretty progressive, in my opinion, stating that withdrawal, meaning like taking everyone, getting off everything, is something I hear a lot. Withdrawal entirely from opioids or medications is associated with a high rate of relapse. We prefer to use the terminology of a return to use. But we know that taking people all the way off opioids or all the way off any kind of medication for their opiate use disorder results in up to a 90% return to use. So we know that MOUD, buprenorphine, and methadone are life-saving medications for all patients, but even more so in the perinatal period. So why do we do MOUD, medications for opiate use disorder, in the perinatal period? When someone is in active use, they go through cycles of what we call intoxication and withdrawal. So they use, they're high, they're sedated, they're euphoric, and then they don't use for a while. They go into a withdrawal state, then they use again, and then they're in this relaxed euphoric state again, and this up and down kind of oscillation is not only distressing for a parent, but also for a fetus. And so, what we know that for fetal development and parental success is that having a steady state is what's going to keep someone feeling okay. So, MAT is kind of the old word for MOUD. So, pardon me for not having changed that. But MAT, particularly buprenorphine or methadone, which are both different kinds of opiates, give us kind of a steady line as opposed to this oscillating effect, which allows us to stabilize people and help ensure more consistent access to fetal growth and fetal health. So, what are our options for pharmacotherapy or treatment of opiate use disorder in pregnancy? The standard of care used to be methadone. We're now shifting to buprenorphine, but basically, my bottom line always is the most effective treatment is the one that the patient's going to stay on. So, a lot of people have had challenging experiences initiating buprenorphine and say, absolutely not. That is not my jam. I'm not going to do that. So, then methadone might be a better option for them. Or if someone lives in rural Washington State, I can say this because I trained in Washington State. There used to be like a 4 hour driving radius where if someone lived in that radius and we were stabilizing them in Seattle, we couldn't discharge them on methadone because there was no clinic for them to go to. So thinking about geographic and other social determinants of health and the ability to access treatment, especially for these unnecessarily heavily federally regulated medications like methadone. That is a political side note that I will save for later if you want to talk about it. Naltrexone or Vivitrol are safe in pregnancy. We use them less commonly. They are less effective than buprenorphine or methadone. I'm not going to talk about it too much today, but if you're interested, please feel free to contact me offline. And then the last option is detoxification, which we know from here that that is not the standard of care and that can result in up to a 90% risk of a return to use. However, if that's what a patient wants and they are and I provide them all the education that they need to make an informed decision, then I'm going to support them with that too. And that's what's really important is that the best care is patient-centered care and creating a clinician patient relationship that results in the patient wanting to return, even if there's a difference in philosophy or recommendation moving forward, for a patient to know that, like, yes, I want to go the detox route, but I know that if I'm struggling, I can come back and no one's going to judge me. That is what's going to be best for that patient. We're not here to change people's minds or coerce them. We're here to like walk alongside them in their recovery journey and give them all the tools possible to give them the best chance at success. So, like I said, buprenorphine is life saving, methadone is life saving. We know for every week of medication for opiate use disorder that is prescribed in the peripartum period, that the overdose risk reduces by 2%. It also, and we know that that's a particularly high risk for when we're thinking about morbidity and mortality in like maternal morbidity and mortality in the United States. The peripartum period, particularly for patients with substance use disorder, that was quite a tongue twister, is a really high risk for morbidity and mortality, particularly with hormonal and mood changes in the postpartum period. The risk for overdose can be incredibly high, along with all of the stressors that come with child welfare involvement and things like that. I can tell you the 2 peripartum overdoses that I have devastatingly witnessed in my career have both been individuals who overdosed within a week of having their children removed from their care by child welfare. And child welfare is there for a lot of good reasons. And we know that child and family separation is traumatic and impactful to the health of parents as well. So this slide is here to say medications for opiate use disorder are life-saving, particularly in the perinatal period. We're going to do a quick review of these medications. So for many of you may be familiar with brand name buprenorphine, Suboxone, Subutex, Zubsolv. We used to only prescribe mono product or buprenorphine only, like Subutex in pregnancy, because there wasn't a lot of data of naloxone in pregnancy. We know now it's fine to do either way. And I think if one thing I can get out there is that the naloxone in Suboxone is not clinically significant when taken as prescribed. If you take it sublingually under the tongue as it is prescribed, the naloxone is not absorbed to any clinical degree and is eliminated in the urine. It's mainly there as a misuse deterrent, so people can't dissolve and then inject their buprenorphine as a part of misuse of pharmaceuticals. It comes in a lot of different formulations. Patients have very strong feelings about which one they get. Whatever works for them works for me. Some providers are hesitant to prescribe buprenorphine mono product because it doesn't have the naloxone in it and concern for misuse. I think harm reduction relatedly, I'm happy to prescribe whatever is going to help the patient. And we also have longer acting injectables like Sublocade and Brixadi, which are long acting injectables. And those too are safe in pregnancy. If you're interested, they are technically not FDA approved for use in pregnancy, but I've done the deepest of dives into the solvents that are used in those injections and the doses and safety studies. And I'm happy to review that with anyone who's interested. Buprenorphine can be prescribed in any clinical setting, up to every 3-month prescriptions. So you don't need to go to a special clinic. I mean, you might need to go to a special clinic, but you don't need to go to like a methadone clinic to get it. You can get it from a primary care doctor. Another thing to consider about buprenorphine is that because it has really high affinity, meaning it locks on real hard to the opiate receptor and is a special kind of opiate in that it's both, we call it a mixed agonist antagonist or partial agonist antagonist. It serves as overdose prevention. So someone who's on a therapeutic dose of buprenorphine has a significantly lower chance of overdosing because fentanyl can't quite make it to the opiate receptor because the buprenorphine is there. So if you have clients that are on buprenorphine, they'll tell you I used, but it wasn't even worth it because I didn't get high. It's because the buprenorphine has a higher affinity at the mu receptor or the opiate receptor in the brain. Methadone basic. So methadone is an opiate agonist, so a stimulator of the opiate receptor. And it is very heavily federally regulated. There's a lot of rules about the prescription and acquisition of methadone. It can be a dangerous medication, but when used appropriately, like I said, is life-saving. Daily dosing is usually standard of care at the beginning, and then as people stabilize, they can get what we call take-home doses. For all MOUD, people need an increased dose in pregnancy. I have to fight with insurance programs about this all the time. The enzymes, and it's, I think I hear a lot of patients tell me, oh, it's because the baby's getting some. If that helps people understand it, that's fine. I will just, for this audience, say that it's actually because of the increased activity of enzymes in the liver during pregnancy that metabolize or break down medications faster. So, methadone, which is normally once daily in the morning dosing, in some pregnant individuals, they will, in order to get on a dose that keeps them well or out of withdrawal for 24 hours, you have to crank up the dose pretty high. But then you have an issue where they're sleepy during the day and in withdrawal in the evening. And that's because their liver enzymes are metabolizing through that methadone dose faster than when they weren't pregnant. So for many individuals, they are much more stable on a split dose or a twice daily dose of methadone during pregnancy. The restrictions around split dosing or BID or twice daily dosing have relaxed a little bit federally, but I would say that has yet to trickle down in a significant way to most local OTPs or opiate treatment programs or methadone clinics. Like I said, there can be barriers based on geography, transportation, childcare, which is why it's so amazing when different OTPs or methadone clinics are able to address social determinants of health in their program administration. There's a lot of stigma about people being on methadone, nodding out all the time or being sleepy. When someone is on the appropriate dose of medication for opiate use disorder, they're going to look like themselves. So if someone is sleepy or falling asleep or sedated who is on methadone, there's something else going on. Either they are using on top of their methadone, they're not on the right dose, or they could be sick. I think a lot of times when we have patients with substance use disorder, there is a diagnostic bias that happens that whatever is happening to a patient has to be because of the drugs. And we really have to, as clinicians, keep our diagnostic and differential diagnostic brains really wide and open, particularly with individuals with HIV who may or may not be immunosuppressed, that we can't just immediately blame an altered mental status on drugs. We really need to think about the patient we have in front of us. And substances are certainly a part of that consideration, but we need to think about the patient as a whole person. Like I said, Vivitrol or naltrexone are FDA approved for the treatment of opiate use disorder. It comes in oral and monthly injectable formulations. It's an opioid blocker. There's no significant survival benefit like there is with buprenorphine and methadone, and there's a really high risk of overdose when someone discontinues treatment. So with buprenorphine and methadone, people maintain some degree of opiate tolerance. So if they were to use, they are in a position where they're less likely, they have some degree of overdose or some degree of tolerance, so they're less likely to overdose. With people on naltrexone, they usually go from using zero because they're on an opiate blocker. If they use, it's not going to do anything for them. And then as soon as they stop taking their tablet or they don't come back for that second shot, they're at very high risk of overdose. It can also be really complicated for postoperative pain management. I will say in the battle, for those of you who are in the Midwest and the West Coast, dealing with very significant rates of methamphetamine use and methamphetamine use disorder, we don't have the rock star medications for stimulant use disorder that we have for opiate use disorder. There is some evidence for a variety of different medications in stimulant use disorder. One of the most effective combinations is every 3-week Vivitrol. So this is the depot naltrexone shot or the monthly naltrexone shot plus bupropion high dose or Wellbutrin. I have seen folks do that in pregnancy. You just have to be thoughtful as you approach full term or delivery date that you might want to switch from the injection to tablets for naltrexone, because having a long-acting opiate blocker on board when you do a C-section is challenging for pain management. And I have seen opioid sparing or non-opioid focused pain management strategies for when we do need to do surgery for people on Vivitrol. And if you're interested in that, I'm happy to talk to you about it. But it just complicates things, especially if you're not in a location where the OBGYNs or the surgeons available are familiar with these medications. So let's talk a little bit about medical comorbidities of opiate use disorder, or really any substance use disorder in pregnancy. Of course, HIV and syphilis are major things that we interact with and that we screen and test and treat people for. Hepatitis C is also a major thing as well. There's the social determinants of health, so poor nutrition, toxic stress, limited prenatal care, other exposure. So anyone using one substance is more likely to be using another substance. I am guilty of sometimes when I have a patient actively using fentanyl and cocaine, sometimes I forget that nicotine is actually nicotine is as dangerous or more dangerous to a pregnancy or developing placenta than opiates. And that's something to always remember, that any substance that a fetus is being exposed to, even if it's less acutely scary in terms of like morbidity and mortality of the parent, is something that we need to address as well. So infectious diseases, of course. And then we also have a lot of patients who, with histories, particularly of injection drug use, have faced serious bacterial infections in the past. That's like your endocarditis, which is a heart valve infection, or an epidural abscess, or an infection around the spine. Something that I've encountered a lot with people in recovery is people with histories of epidural abscesses and difficulty with epidurals for labor. So thinking about spinal pathology and ability to access different kinds of pain control for labor is something that I encounter a lot. Pregnancy is also a really complicated state for the heart. So anyone with a history of endocarditis probably needs additional care and workup during pregnancy to make sure that they don't have any valvular or valve abnormalities that could impact their cardiac health during their pregnancy. We also have an increased risk of preterm labor, fetal growth restriction, and abruption. This is more so with nicotine and stimulants. Coming back to HIV-related care a little bit, we can do PrEP in pregnancy. Data universally, we underprescribe PrEP or pre-exposure prophylaxis for people who use injection drugs. And we are doing our best to kind of increase the uptake of that. But just to remind everyone, we can also do PrEP in people who are pregnant. And I won't go into the details too much about which agents we use, but always, as we're thinking of comprehensive care for patients with substance use disorder in pregnancy, if they are not HIV positive, how can we prevent them from seroconverting? Special considerations for HIV positive patients. Patients with substance use disorder are more likely to present late to prenatal care, and thus, if they don't know they have HIV, have a delayed diagnosis. There is the double stigma load of carrying their positivity and their substance use disorder, particularly in pregnancy. We know that integrated care is more accessible care. And we know just one thing to consider is that antiretrovirals can alter the metabolism of methadone. So it's always important for methadone prescriber and ARV prescriber to be in close communication so we can titrate medications as necessary. This is a paper I look back at a lot of the effect of HIV, antiretrovirals, and genetics on methadone pharmacokinetics. If you're a pharmacology nerd, there's different gene variants and things like that that we can get into. But if you're interested in that, I'm happy to talk more about it. So we're going to talk a little bit about the impact of intrauterine substance exposure on parenting with substance use disorder. So breast or chest feeding, this is an incredible resource from the Washington State Department of Health. There's a link connected. That is a very patient-centered harm reduction guide to the safety of breast and chest feeding for people who use drugs. The most important thing is to center what the birthing parent desires and make sure that they have good education on what's going on. So we know that people in recovery slip up sometimes. It is unreasonable to think that anyone in recovery it's unreasonable to think that people don't slip up and stuff doesn't happen. I want people to be able to continue breastfeeding with the knowledge that they have available to them and be safe and get back stable when they need to. So bottom line is it's hard to find evidence-based education on lactation and substance use, but this is a great guide. We know that pumping and discarding milk after substance use can protect infants from substance exposure. We don't necessarily need to permanently discontinue breast or chest feeding after substance use. And major message to internalize is that breast or chest feeding is safe and highly recommended for patients on MOUD. The amount that's released into breast milk for buprenorphine and methadone is actually clinically insignificant. We talk about breastfeeding helping with withdrawal for infants. And the reason why it helps is because breastfeeding is good for infants, period. It's not necessarily that they're getting that much methadone or buprenorphine in the breast milk that helps taper them off. It's more the skin to skin and co-regulation that helps with withdrawal. So again, overall guidance, MOUDs are safe in pregnancy, in lactation, support people if they want to breastfeed, support lactation if people want to. And they give actual guidelines on how long you should probably wait to clear certain substances while you're pumping and discarding milk, rather than saying, if you use substances, period, no breastfeeding. Like, let's actually give people information to be able to get the benefits of chest feeding if that's what they want. This is a little fuzzy, but the guidance on chest feeding and HIV is different depending on what academy you look at. In general, I think the bottom line is that a patient directed conversation around it based on the control of their HIV infection is what is best. So the American Academy of Breastfeeding Medicine endorses the 2010 WHO statement that exclusive breastfeeding reduces mother-to-child transmission. And depending on where you are, the concern for, water clarity and safety is important. The American Academy of Pediatrics says no breastfeeding if they have HIV infection, but it really depends on who you're talking to and what society you're looking at. And in the end, we should be talking to our patients about it. Child welfare involvement. I spend more of my time on this than I would like to. The main messages I want to get across are that parental substance use is not the equivalent of abuse or neglect. Different states have different laws that may contraindicate that, but I will say that is the kind of medical child abuse pediatrics standpoint. Does parental substance use increase risk of abuse or neglect? probably, but we can't assume that they are one and the same. We need to approach each patient and family as individuals. This is a great resource from If, When, How. If you're not sure about prenatal drug exposure legality and restrictions and rules in your state, take a look at this If, When, How resource. It goes state by state, looking at CAPTA, which was a law that was passed in 2020. I can't remember, sorry if I'm wrong, about perinatal drug use reporting requirements. State by state, it varies significantly. Some states, there's a difference between a notification. So, like, hey, just so you know, someone who's on buprenorphine had a baby. We're not concerned, but like we want to let the state know just for statistics, versus a report, hey, I've got someone who's actively using substances and is struggling and just had a baby. That's a difference between a notification and a report. A notification would not open up an investigation, whereas a report would. Some states, there's no difference between those two things. If you call child welfare, you're calling child welfare, and they decide if they open up an investigation. I apologize. This is DCPP. This is what we call it in New Jersey. I practice in a state where there is mandatory child welfare reporting for any controlled substance use, prescribed or non-prescribed, in pregnancy. So even if I have a patient who has been sober for 15 years on buprenorphine, I still have to report to child welfare after they deliver. In some cases, it's benign, and in a lot of cases, a report to child welfare is not benign. We know that there are disproportionate impact on families of color. They're more likely to experience reports and more likely to experience family separation from child welfare involvement. And there is a significant amount of intergenerational trauma that comes from discrimination in child welfare. I think this is an area of a lot of moving parts and a lot of advocacy right now. And I'm curious to see where things are going in the future. But the way I handle things right now is I think about it in the lens of harm reduction. So I always, the second I meet my patient, I don't say like, hi, welcome to clinic, you're going to get reported to child welfare. But I like to be transparent with people, be like, hey, part of your care is that we're going to help advocate for you. We live in a state where this is the rule. Here's how we're going to help you. So basically, we help create plans of safe care, or POSCs, that help indicate like what kind of resources that someone has available to them, how they're doing, what their supports are. We make proactive calls to child welfare to be like, hey, we've got this amazing patient. They're doing really well. We just wanted to let you know they're pregnant and that you're going to get a call so we can advocate for them. We have a medical legal partnership. So we have a free lawyer available to help advocate for patients. And I think the main thing that to take out of this is the philosophy of nothing about you without you. There are a few things more traumatizing than like an unexpected child welfare worker showing up in someone's postpartum room. So if at all possible, if it's safe, I make child welfare calls with my patient in the room so that they don't have to feel like something's happening without their knowledge and that they're being blamed or antagonized in any way, but that this is like a necessary process and we want you to be involved rather than this happening to you. People experience a lot of shame and guilt about substance use in pregnancy. What we know, particularly with in general, is that alcohol is the only true teratogenic, meaning it like causes birth defects, basically, is the only true teratogenic substance. Other substances impact placental development and fetal development in different ways. And we can kind of go into that offline. There has been some concern about fentanyl related kind of disorders. This has not really been borne out in the literature, but I would like to just like note that like patients see this kind of stuff in the news and get concerned about it. And the shame and guilt doesn't help people get better. And just really being able to support our patients that like moving forward through recovery is the best kind of process for them and their kiddos is the best thing we can do for them. In terms of developmental sequelae, it's really hard to know for us to study the impact of intrauterine drug exposure on longer term outcomes because there are so many confounding variables. Like, if they were exposed to fentanyl while they were in utero, but they grow up in a sober, happy, supportive, loving home, they're probably going to do pretty well. But if they grow up in a non-sober, chaotic, poverty, like complex situation, they are more likely to experience developmental sequelae. So, what we know is that growing up in a using household impacts intelligence and emotional well being more so than the perinatal exposure. So, what's important is getting people into and solidly in recovery rather than focusing on what happened in utero. Briefly, neonatal management. Again, I'm not going to get too much into like HIV, vertical transmission stuff for neonatal management, but for patients on medications for opiate use disorder, neonatal withdrawal is an anticipatable side effect, not a complication. There's a lot of different ways to manage it. And I think proactive counseling for patients is the best thing we can do for them. This is about Eat, Sleep, Console, which is a strategy for managing neonatal withdrawal that I won't get into too much. I want to mention it briefly histories of punitive policies. So, states with more restrictive laws about substance use in pregnancy are less likely to have people who are using in pregnancy come in for treatment. That's a shocker. People are scared of incarceration and family separation. 23 states, including the District of Columbia, consider substance use during pregnancy to be child abuse under child welfare statutes. We know that this has a chilling effect on care and that it disproportionately impacts women of color and people requiring public defense. So as we're treating people with the like compounded stigma and social determinants of health of being both HIV positive and dealing with substance use disorder, it's important for us to think about the legal implications that they face and the barriers that that presents to people's care. With that, I'm going to close this presentation and we've got about 14 minutes for questions and answer. I'm going to take a look at the chat to see if I see any questions. I see one here. So, can or do OBGYNs prescribe MOUD? I'm so glad you asked. And the answer is absolutely. There used to be a lot of restrictions to who could prescribe MOUD, both buprenorphine and methadone. Buprenorphine used to require a special X waiver, a special DEA waiver. That was a huge pain in the butt to get. That restriction is gone. So really anyone with a DEA license can prescribe buprenorphine. Methadone is a little bit more complicated because it has to be from people with opiate use disorder are only allowed to get methadone from a certified OTP or opiate treatment program. But there are many OBGYNs or family medicine family medicine docs who practice obstetrics, which is like me, who prescribe MOUD that allow for integrated care. So a pregnant patient can go to an FMOB, family medicine OB doctor, who can treat their HIV, take care of their pregnancy and their substance use disorder. And that's something that OBGYNs can do as well. Or we can create these kind of shared models. So the model I work in right now, our patients come in and they see addiction medicine, then family medicine, and then OB, and they get to go boop, boop, boop down the line so they can get all their care in one place, which is really fantastic. And we know has improved outcomes when people don't have to go 6 different places for their care when they're already dealing with living their lives.
Thank you, Dr. Neeson. There are a couple of questions in the chat. There was a follow-up to the question that was just asked about OBGYNs prescribing MOUD. So the question was, especially if they're going to be in a rehab program with limited availability or stigma that may be a barrier to care.
Yeah, absolutely. So there's so much stigma going on. There is stigma towards pregnancy and substance use recovery, and there can be stigma towards medications for opiate use disorder in pregnancy care. So it's dual, bi-directional there. And I think what the medical establishment needs to do is also make sure that the newer generations of clinicians that are being trained, anyone going into any specialty should have a baseline understanding of treatment of the most common substance use disorders and how that relates to their profession.
Thank you. Another question, can you please advise us where to find guidelines or research on injectable MOUD for pregnancy?
Oh, yeah. It's a little bit hard to find. There are some studies. If there's someone, I can like maybe grab the name of whoever wants that and I can send you the breakdown. There are studies going on right now for both Sublocade and Brixadi in pregnancy. A lot of the information we have is from like rat models, so it takes a lot of like extrapolation. There haven't been any large studies yet looking at fetal outcomes, and I think that's coming down the pipeline. But if you search Sublocade or Brixadi in pregnancy on Google Scholar, you'll get some kind of findings and you'll be able to find some nice resources. I don't think that ASAM or SAMHSA have come out with any like guidelines yet because it's still an off-label use. So you do want to be pretty schooled in being able to discuss the risks and benefits with your patient. But I'd be happy to look into that further and see if there's any good guidelines or kind of like one pagers on that. But right now it's a little bit of like a cutting edge, like harm reduction kind of thing because it's not quite standard of care and off label. But if that's what's going to help keep someone sober, then that's the right thing for them. Absolutely. I prescribe it without pause.
Well, I jotted that person's name down, so I'll be sure
Thank
that you get
you.
their contact
I'll
information.
hook you up. I have a whole PowerPoint about it.
Next question is for pregnant moms on PrEP, what is the follow-up labs?
That's a great question. It depends on which version of which PrEP formulation they're on. But typically, for anyone on PrEP, we need every 3 month labs looking at least HIV status, but also we like to do all STI testing. And then there needs to be some degree of monitoring of renal or kidney function. But that usually only happens like once or twice a year. I don't know specifically if the monitoring labs change in pregnancy. I don't believe they do, and I don't believe there's any additional fetal monitoring that is done either.
Do you know the number of treatment programs in your state that offer residential treatment for pregnant women?
I can tell you, I can count them on one hand, and
Mm.
they don't all follow evidence based medicine. So, not all of them accept patients on MOUD. And it is very rare that I can find a treatment bed for a patient for residential treatment. Many states have what we call PPWs or pregnant parenting women programs or mommy and me programs. We need more, and we need more family based treatment programs. And that is part of my 10-year plan. But it is, I wish I had added, I have a slide about like the percentage of substance use treatment programs that will accept pregnant patients. But the spoiler alert is not that many. And it can be really difficult for a patient, particularly later in pregnancy, to find a residential treatment bed.
So this participant is from Texas, and they're saying that your program sounds wonderful, to have integrated care. Do you know of any other programs around the country that are similar to yours?
Yeah, I think we're really lucky that there are starting to be more and more programs that have co-housed care. The program that I trained at in Seattle, Washington has a similar program. I know there's one in Michigan as well, and it's becoming more and more common. And there have been great literature published recently on the improved outcomes for co-housed care as well. Dr. Poland is, oh, where is she? And this is so cruel, but it's either Michigan or Minnesota, and I get them confused because I'm a Midwest not naivete person. But there are programs out there. They're findable, they're replicable models, and it's doable and it's cost effective for the health system because it reduces ER visits, it reduces poor outcomes, all sorts of things. So this is doable no matter where you are. And if you're interested in starting a program, I'd be more than happy to chat. Awesome.
All right, we have a few more. Has there been any research on, you kind of touched on this just a tad with PrEP, but have there been any research on aptitude, injectable PrEP in pregnant women?
That is a great question. I actually had it on my list to research about that. I believe there is some research. I don't think it's FDA approved for use in pregnancy. My understanding is that primarily people prescribe Truvada because that's where the most data is.
Mhm.
But like with all things, I mean, in pregnancy, there's always a delay in data because it's a protected population and it's harder to do ethical research in the pregnant population because you don't want to give people non-standard of care. So everything's slower in getting like drug related data. And often we know in practice that things are okay, but they'll still be considered high risk in pregnancy based on like categorizations because of the data. I do think that we'll end up using Apretude in pregnancy, but I currently don't think there's a lot of public data about that yet. But I would need to do a full literature review to be able to answer that fully. But thank you so much for asking that. It's also one of my questions.
How do you prepare women for the conversation that you have to report them to DCFS as it relates to substance abuse? And how do you deal with the aftermath of it?
Yeah. Those conversations don't get easier, honestly. And I'm probably a little bit more informal than most physicians. And I think that creating, like, reducing that, like, power mismatch is part of how that can be helpful. And I always say to my patients, look, I'm gonna promise you that I'm gonna be straight up with you. And I want you to know everything that's going to happen up front because surprises are bad. And everyone gets on board when I say surprise, like surprises are tough when you are in early recovery or when you're pregnant. So I'm like, I'm going to give it all to you up front. Some things are challenging, and I'm going to tell you when I tell you something challenging, I'm also going to follow that up with how I can help you. So I'll say, hey, in New Jersey, this is the law. I didn't write it. Let me tell you, I am fighting with the legislation about it. However, this is the law. We know that a notification or a call has to be made after pregnancy, and I'm going to acknowledge how scary that is. So I think acknowledging the fear and trauma that comes with that is a great way to build partnership, to be like, I know how scary that is, and I want you to know that I believe that you are a good mother or a good parent, and to show your faith in that patient and to be able to say, I will advocate for whatever I have to do to help support you in keeping your family together. And I know how scary that can be. So acknowledging the fear, promising your honesty, and telling people things up front, I think are the three ways that you can make that an easier conversation. And then kind of following that up with like, what are some of the harm reduction ways that we can approach this to make this a less traumatizing experience for you? Is how I try to make those conversations a little bit easier, but they're tough. And people are scared, and it's a really hard thing to try to navigate.
Hey, what is your recommendation for SUD individual therapy, examples, frequency, et cetera, for people taking MOUD?
I think it really depends on the patient. Some people hate therapy and it's not going to be helpful for their recovery or have had traumatic experiences with therapy. There used to be a lot of requirements for prescribing buprenorphine and like needing to have a therapist on site. And for some people, buprenorphine is really all they need for their recovery. For some people, if they have comorbid trauma or mood disorders or all stuff like that, therapy is a really important part of their recovery. And my bottom line on that is it's what's best for the patient. So I am so lucky. The coolest thing about well, there's so many cool things about my program, but I have a full-time trauma-focused therapist that works with me. I would say the majority of pregnant people with substance use disorder have some kind of trauma history, and PTSD and things like that can be a huge barrier to recovery. So having that kind of treatment available is fantastic, but it's not a one size all fits all. And I'm glad that there's more flexibility with there used to be rules about needing to have a therapist in the clinic where you were to prescribe buprenorphine. And the reality is, like, for someone who's been on buprenorphine for 10 years, like, they really might not need to see someone. And so I think kind of working with an individual patient and making an individualized care plan is going to be the best thing for them. But I don't think it's a necessity to be on MOUD or really any kind of medication for substance use disorder.
Okay, so we have a few questions. I know we have a hard stop right at the top of the hour, so I'm gonna think maybe we can jot some down and
Yeah,
maybe
I can
answer
email
them.
people. Sorry, everyone. I have a patient at like, I can probably push it to 104 if I have to, but patients come first, and I'm sure you all understand.
Mhm, absolutely. So I'll try to go quick. Okay, so do you know what other PrEP options there are for women who are not insured, who are also pregnant to access Truvada, since Descovy is for only those assigned male at birth? And they asked this because since Gilead is no longer providing Truvada through advancing access to insured people since there is now a generic version.
I wish I had a good answer to that. The way I've gotten around that, I have grant funding from the state where I can help pay for prescriptions when people don't have insurance coverage. And so just like being creative about the ways we're using grant funding and money and is one way that we can do that, but that is a huge barrier to access. I think also considering FQHC or federally qualified health center based care, they often have federally subsidized pharmacies that you can have sliding scale pay out of pocket for PrEP. So that's one other thing to consider, but that's a huge barrier. And we're always navigating patient assistance programs and things like that. So it's a huge pain in the neck. And I only have solidarity to share with you, unfortunately.
Okay. All right. Well, thank you so much. We're going to respect your time. It is right at the top of the hour. All please take a moment to open the chat. My colleague dropped the link for the evaluation. We really appreciate your feedback, and we invite you to join us next month for our next training. But thank you all for being here and enjoy the rest of your day and happy Super Bowl weekend.
Thank you, everyone, for all the work you do, for being out in the trenches. You're doing the good work, and I'm grateful to all of you. Thank you.
Thank you so much, Dr. Neeson.
I'm going to pop my email in the chat in case people want to contact me separately with questions.